So this is the classical exam slide of rhinosporidiosis, where you can see variable sized sporangium. You can see variable sized sporangium, as you can appreciate over here. Within the sporangium, you can see the endospores or the sporangiospores, as you can appreciate over here. And in between the sporangium, you can see chronic inflammatory cells. You can see the chronic inflammatory cells. So this is the high power view of an individual sporangium, which is composed of 1000 plus endospores, as you can appreciate over here. And very importantly, you can also come across a metaplastic squamous epithelium, as you can appreciate over here. So these are the most important histological features of rhinosporidiosis. With this, we have completed the part 1 of the infectious disease lecture, and in the next lecture we are at the center number 1. We are seeing the sulfur granule containing your gram positive bacteria with branching filaments. Then just outside there is the eosinophilic material, that is basically eosinophilic amorphous material with a club shaped configuration, which is representing antigen antibody reaction with debris, also called as slender Hippel reaction. Then surrounding that, the third important thing that you are having from here to here, you are basically having suppurative inflammation. You are having suppurative inflammation over here. And fourthly, if you see outside this area of suppurative inflammation, you are having the layer of chronic inflammatory cells comprising lymphocytes, plasma cells, histiocytes, and few multinucleate giant cells. So this is all you have to remember under the microscopic examination of actinomycosis. One, that is the layer number, which is marked A. You can see over here in pink. What is this layer? This is basically this layer I am talking about. If I show you with yellow, this is the layer I am talking about. This is the first layer, okay, and I am repeatedly saying that this is basically the host tissue reaction, okay. This is the host tissue reaction. This is the host tissue reaction. Then there is the layer number B, okay. If you look at the layer number B over here, okay. So this is the layer number B, as you can appreciate. This is the laminated layer. So this layer number B, as you can appreciate over here, this layer number B is basically your laminated layer, the acellular laminated layer. That is the layer number 2. Then there is a layer number 3, as you can appreciate, which is marked as C over here, which is actually the germinative layer. Which is the germinative layer. It is a cellular germinated layer. Okay, this is the layer number 3, that is your cellular germinative layer. Okay, then comes your number D. As you can see, what is D? What is this entire D? Yes, this is actually a brood capsule. This D is a brood capsule which is containing multiple protoscoliosis containing hooklets. This is a brood capsule. Okay. Myself, Dr. JIBRAN Ahmed, presents to you Simply Pathology, and today we are back with a very important session. Today we are going to start with the infectious disease part 1, and this is going to be a series of lectures. Now, if you see, there are innumerable number of organisms that we deal with. It is not possible for us to discuss each and every organism, but what we will do, we are going to shortlist some of the very important organisms which are of practical importance, and secondly which are asked in the exams, both in theory as well as practical. Now, infectious diseases or this particular topic is very, very important from the exam point of view, and it becomes little bit difficult for the residents because this is a very neglected topic, both by the residents, both by the college as well. There are few reasons for this, because in the college you don't come across these cases very frequently, so you tend to ignore and you tend to shift your focus from the infectious disease. But during the exam, remember, the examiner carries 1 or 2 infectious disease slide. So pay a lot of attention over here. Okay. So first we are going to discuss the classification of the infectious disease. As you know that the infections can either be of viral origin, bacterial origin, fungal and parasitic. So coming to the viral infections, we are having acute and chronic viral infections. So acute infections include measles, mumps, poliomyelitis, okay, dengue, COVID-19. Now the ones which I have written in red are the ones which will be discussed, and they are of importance, okay, because they might be asked in your exams, both in theory as well as in practical. Okay, coming to chronic viral infections include herpes simplex, varicella zoster virus, cytomegalovirus and Epstein-Barr virus. Okay, now coming to the bacterial causes of infections, if you see, so they are divided into gram positive, gram negative, obligate intracellular organisms, mycobacterial, spirochete and anaerobic organisms. So under the heading of gram-positive organisms, we have Staphylococcus, Streptococcus, diphtheria, anthrax. In gram-negative, we have Neisseria, Pseudomonas, chancroid, granuloma inguinal, plague. Under obligate intracellular organisms, we have chlamydial infection. Now, mycobacterial species includes tubercular as well as non-tubercular mycobacterial infection as well as leprosy. Now, remember all these three are very important from your exam point of view. And remember that TB and leprosy has already been discussed as a separate session. Okay, so we are not including them in this particular series. Then under spirochetes, we are having syphilis, okay, Lyme's disease, and anaerobic bacteria, we are having Clostridial infection. Now, what is more important from the exam point of view are the fungal infections and the parasitic infections, which are very frequently asked in the exam. The examiner is carrying a slide, okay. So, among the fungal infections, we are having yeast and mold. Among the yeast, we have candidiasis, cryptococcus and pneumocystis infection. And among the molds, we have aspergillosis, mucormycosis, also called as zygomycosis. Now, under the parasitic infections, we have protozoal infections as well as we have metazoal infections. So, under protozoal infections, malaria is very important. Leishmaniasis again is very important. Other infections include toxoplasmosis and trypanosomiasis. Under the metazoal infections, we have strongyloidiasis, cysticercosis, hydatid disease, filariasis, schistosomiasis. So again, I am repeating, the ones that I have highlighted in red are the ones that we will discuss because they are important from your exam point of view. Okay. So let us begin today's topic of discussion without wasting any time. Okay. So the first very important exam slide that we are going to discuss over here is your hydatid cyst. Okay. It is a tapeworm, okay, Echinococcus granulosus causative agent causing hydatid cyst. So, Echinococcus granulosus, it is a complex of closely related organisms, okay. It is the most common species causing human disease worldwide. So, Echinococcus canadensis and orthlepi, they are also causing human disease. The species are differentiated via molecular means. Remember, one other species is the Echinococcus multilocularis. Now, this is a human infection. It is far less common but has a more aggressive and invasive growth that resembles the tumor and is not contained within a large parent cyst, unlike your Echinococcus granulosa species. Alveolar echinococcus is caused by infection with larval stage of Echinococcus multilocularis. So this invasive variety, which is less common, basically infects the alveolus, okay, and they lead to alveolar echinococcus infection. So coming to the basic introduction, if you see Echinococcus granulosus, it is a cestode parasite. It is a tapeworm that is causing hydatid infection. It is basically caused by the larvae that develop after the ingestion of the tapeworm egg. Now, these tapeworms, they have a very complex life cycle requiring two mammalian hosts, a definitive host in which the worm reaches sexual maturity and an intermediate host in which the worm does not reach sexual maturity. Hydatid cyst is caused by the ingestion of the eggs of Echinococcus species and formation of cyst in the organs where the parasite larvae is deposited. Now, for Echinococcus granulosus, remember the definitive host is a dog and the intermediate host are sheep. Whereas for Echinococcus multilocularis, fox is the most important definitive host and rodents are intermediate host. So, how does the infection happen in case of human being? Humans, in fact, they are accidental intermediate host infected by ingestion of food contaminated with eggs which are shed by dogs or foxes. Okay. Eggs, they hatch in the duodenum and the larvae invade the liver, lungs or bones. Larvae are released from the eggs and are transported to the liver by the portal vein. Infections in humans is usually asymptomatic, but large cyst in the liver can cause abdominal pain or obstruction, and pulmonary cyst can cause pain, cough, hemoptysis. Caution is warranted if surgical removal of the cyst is considered as anaphylaxis and/or dissemination of organisms can result from spillage of the cyst content. So what is very important, so in the exam, the examiner asks you what is the Echinococcus granulosus complex of species. So you have to say that this is the complex of species in which the most common species is Echinococcus granulosus. Other important species include canadensis, orthlepi, and one very important, less common but invasive variety which is causing alveolar diseases, Echinococcus multilocularis. So this is one very important exam viva question. Second thing is a human a definitive host? No, human beings are accidental intermediate hosts who are actually ingesting, okay, the food which is contaminated with the eggs of the definitive host, that is the dogs and the foxes. And when the human is ingesting that particular egg, the egg hatches in the duodenum and the larva is basically formed, which reaches the liver via the portal circulation, and wherever the larva goes, it encysts itself and forms cyst. Okay, this is the basic introduction to this hydatid disease of the human beings that is happening. Okay, so this is very, very important for you to understand. Basically, the liver is one important site, okay, in which the person is presenting with abdominal pain obstruction, and the lungs are another important site where they present with pain, cough and hemoptysis. Okay, now coming into the details. Now, clinical features, if you see, it depends on which site is involved, right? So the cystode or the tapeworm infection, is widespread across the world, often asymptomatic for years due to the slow growth, but hepatic and pulmonary symptoms are most common. Now, the symptoms can be secondary to the cyst rupture or compression of other structures also. So, as I told you, the symptoms are basically because of the organ which is involved. So, most commonly liver is involved, so there will be abdominal pain obstruction. Or if the lungs are involved, there will be pain, cough and hemoptysis, right? But if there is compression of other organs also, for example, in the liver they are growing, so as a result there can be compression of the bile duct, so there can be bile duct compression. Okay, there can be infection of the bile duct, that is cholangitis, or rupture can be there into the peritoneal or the pleural cavity. Now there can be portal hypertension secondary to portal vein compression by the cyst, or sometimes they are also presenting in the breast. Okay, so they can present as a breast mass. Rupture of the cyst in the lungs may cause intense coughing, vomiting of the cystic materials. Clinically also they might resemble a carcinoma as well. So you need to do further evaluation to rule out, okay, cancer. Now the common cause of hepatic cyst, they are mainly caused by the larval form of Echinococcus tapeworms, mainly Echinococcus granulosus. It is most common and it causes a cystic disease. Okay, remember, the Echinococcus granulosus, most commonly it causes the cystic disease, whereas the Echinococcus multilocularis, it is less common but it causes alveolar disease. So remember, the hepatic cysts are mainly caused by the Echinococcus granulosus, whereas the alveolar disease is caused by the Echinococcus multilocularis. Now, Echinococcus granulosus, as I told you, it is the most common, causing the classic hydatid cyst in the liver, and not only liver, they can also cause cyst in the lungs as well. It is not like that the Echinococcus granulosus will only cause cyst in the liver. They can also cause in the lungs. Okay. E granulosus cyst, they are having three important layers. Okay. So there is an inner layer comprising of a germinal layer with brood capsules and protoscoliosis. Okay. The adult tapeworm heads, I will show you with the help of diagram all the layers. So please pay attention right now. Then there is the middle layer of the cyst. There is a hyalinized, laminated and acellular material. And an outer layer consists of granulation tissue and fibrosis. So remember, there are three layers, okay, of the cyst. Okay, the inner germinative layer giving rise to the protoscoliosis, brood capsule, and finally the daughter cyst. The second layer is basically the hyalinized, laminated acellular layer, and third is basically it is a reaction of the host to this particular cyst formed by granulation tissue and the fibrosis. So there are three important layers of the hydatid cyst. Remember this point. Okay, it's a very, very important exam question. In the breast, they present as a slow growing lesion, may mimic fibroadenoma, phylloids or rarely intracystic carcinoma, may become infected and be indistinguishable radiologically from an abscess. Okay, so I hope this is very, very clear. What are the basic clinical features? Okay, which species are involving mainly the liver, which species are involving the alveoli, and we have also seen which is the most common cause of the classic hydatid cyst. It is the Echinococcus granulosus and it is most common cause. Mainly it is causing hydatid cyst in the liver, most common site, and secondly they can even cause in the lungs and other site as well. Now, E granulosus cyst, they are found in the liver in about 2/3 of the cases. In 60 to 70% of the case, they are found in the liver, with 5 to 15% in the lung, as I told you, and rest can occur in the bones and brain. So what is very important, hydatid cyst, you always remember liver. Okay, the site is the liver, but you failed to answer this question in the exam. So what are the other sites of hydatid cyst? So the answer is lungs, bones, brain. Okay. In the various organs, the larva lodge within the capillaries and first incites an inflammatory reaction composed principally of leukocytes and eosinophils, that is the mononuclear leukocytes and the eosinophils. Many such larvae, they are destroyed, but the others insist. So majority of the larvae which hatches, they are destroyed, but some larvae, they form a cyst around themselves. Okay, they form a protective covering around themselves and they persist. So much of the larvae they are destroyed, but some of them they encyst, and the cyst begins at microscopic level and progressively increase in size, so that in 5 years or more they may achieve dimensions more than 10 centimeter in diameter. They grow into cyst, enlarging at a slow pace of about 10 to 15 mm per year, or 1 to 1.5 centimeters per year. Now, enclosing an opalescent fluid is an inner nucleated germinative layer. This is the layer number 1, and the layer number 3, and then there is an outer opaque non-nucleated layer. Okay. Now, the outer nucleated layer, non-nucleated layer is distinctive and has innumerable delicate lamination. This is the layer number 2. The layer number 3, outside this opaque layer, there is a host inflammatory reaction that produces zone of fibroblast, giant cells and mononuclear eosinophilic cells. In time, this forms a dense fibrous capsule form. So, this is the third layer. As I have already discussed the 3 important layers over here. So, please remember this in your exam. It is asked in your exam. Now, very importantly, okay, if I just show you, this is the innermost layer. Suppose this is the innermost layer, and from the innermost layer, what happens? That protoscoliosis, they are formed. Now, few such protoscoliosis, they are going to insist to form brood capsule, and such brood capsules finally enlarges to form daughter cyst. So, remember this point. I will show you with the help of a diagram also. If this concept is not clear, you will not get marks. Okay, this is the inner layer. So, the inner layer is a germinative layer from which the protoscoliosis they arise. Some such protoscoliosis is going to group together to form brood capsule, which ultimately is going to enlarge to form daughter cyst. So, daughter cysts often develop within the large mother cyst. These appear first as minute projections of the germinative layer, that is the protoscoliosis, that will develop central vesicles, and they will form tiny brood capsules, as I told you, which in due course will give rise to daughter cyst. Cysts are composed of protoscoliosis and daughter cyst within the brood capsules. Okay. Okay. So, these are the protoscoliosis, these are the daughter cyst. Okay. And you are having the brood capsule over here. Okay. Degenerating scolysis of the worm produce fine sand-like sediment within the hydatid fluid, that is called as the hydatid sand. So, this is a very important diagram. This is basically a gross image of a hydatid cyst. Now, what we see over here in the outer aspect, we are seeing an adventitious layer or a fibrous layer. The third important layer is a host tissue reaction. Then we are seeing a laminated layer over here. Okay, this is acellular laminated layer. And on the inner aspect, we can see this germinal layer or the germinating layer, layer number 1. Okay. So, if you see, this germinative layer is giving rise to what is known as scoliosis or protoscoliosis, whatever. And you will see that such a scoliosis, they encircle to form what is known as a brood cyst or the brood capsule, which enlarges, ultimately giving rise to the daughter cyst, as we can appreciate over here in this particular diagram. Now, if you look at the gross description, Echinococcus granulosus, typical cyst is spherical, up to 30 centimeters or more in diameter. They have a fibrous rim and frequently contain several daughter cysts, as I have already shown you. Whereas Echinococcus multilocularis, they are multilocular necrotic cystic cavities containing thick pasty material. The fibrous rim is absent in case of Echinococcus multilocularis, and this is how you differentiate it from granulosus. Now, microscopic description or histologic description, if you see, I have already repeated this and I am repeating it once again. The cyst wall is having 3 important structural components. Outer acellular laminated layer is there. Okay. Then you are having the germinal membrane, a transparent nucleated layer from where the protoscoliosis, they are attached to this particular membrane and they are budding from it. So, this is the layer number 1. This is the layer number 2. Outer acellular laminated component and the inner germinative layer is there from which the protoscoliosis are budding. Protoscoliosis, they are ovoid and they contain hooklets which are birefringent under polarized light, and they have a sucker. Outer fibrotic layer with granulation tissue with increased eosinophils also exists, which forms the third important layer. The third important layer, and this is basically because of the host tissue reaction. Whereas this is for the Echinococcus granulosus, the typical hydatid cyst. Whereas for Echinococcus multilocularis, irregular cyst with laminated membrane without any germinal membrane or protoscoliosis. Invasion of the liver parenchyma can create inflammatory or granulomatous reaction or extensive peripheral necrosis and fibrosis. Now, this is a very important diagram to make you understand about the different layers. So, the layer number 1, that is the layer number, which is marked A. You can see over here in pink. What is this layer? This is basically this layer I am talking about. If I show you with yellow, this is the layer I'm talking about. This is the first layer, okay, and I'm repeatedly saying that this is basically the host tissue reaction, okay. This is the host tissue reaction. This is the host tissue reaction. Then there is the layer number B, okay. If you look at the layer number B over here, okay. So this is the layer number B, as you can appreciate. This is the laminated layer. So this layer number B, as you can appreciate over here, this layer number B is basically your laminated layer, the acellular laminated layer. That is the layer number 2. Then there is a layer number 3, as you can appreciate, which is marked as C over here, which is actually the germinative layer, which is the germinative layer. It is a cellular germinated layer, okay. This is the layer number 3, that is your cellular germinative layer, okay. Then comes your number D. As you can see, what is D? What is this entire D? Yes, this is actually a brood capsule. This D is a brood capsule which is containing multiple protoscoliosis containing hooklets. This is a brood capsule, okay. Remember, individual such protoscoliosis, they are actually budding off from the germinal layer, as we can appreciate over here. As you can see, this is an individual protoscolex along with the hooklet. This central part, you can see, this is the hooklet, as we can appreciate over here. So as you see over here, the number E which is marked over here, this is the E structure E. This is basically the protoscolex. And what is this inside the E? This is the visible hooklet. So the examiner is going to ask each and every point in details to you. He is going to mark everything under the microscope and he will ask you the individual parts if you realize this. If you understand this concept, very good, you are going to answer everything. If you don't understand this, please see this video again so that you are better able to understand this concept, okay, the different layers and what are the different structures over here. Again, this is another image over here. What we can see, can you see the laminated layer, acellular, there are no cells. Why lamination? Because multiple is like a lamina. So it's a laminated layer like this, if you can appreciate over here. So cystic structure with laminating fibrous wall and inner germinal layer. So this is the acellular laminated layer, and what is this? This is the germinative layer. This layer is the germinative, cellular germinative layer. Now you can see over here, this cellular germinative layer over here is giving rise to a protoscolex. Can you see a protoscolex with the visible hooklets? Can you appreciate over here? Okay. So it is actually, there are multiple such cysts over here, means multiple such protoscolex is there over here containing multiple hooklets, and they enlarge to form the daughter cyst actually, okay. Now over here we can again see, this is the germinative layer, this is the laminated layer over here. Multiple protoscolex can be appreciated over here, each with their own hooklets can be appreciated, okay. They are having their own hooklets over here, okay. Now this is another image where we have this is the past stained image. Again, beautiful lamellated structure can be appreciated over here, as we can appreciate in this diagram, okay. This is another image highlighting the individual protoscolex, as we can appreciate over here, okay. They are also having a chain of hooklets over here, and very importantly, multiple dispersed calcified spherules are also present over here, okay. And you can see this can also be highlighted using the past stain and the laminated layer, and again the laminated structure can be highlighted using the Grocot's silver stain, okay. So this is incomplete discussion of the hydatid cyst, okay. Now we are going to discuss about the basic differential diagnosis. Now always remember that the hooklets are acid fast positive on Zn stain, and they also stain positive with the GMS, okay, Grocot's methamine silver stain. The differential diagnosis is other tapeworm infection like cysticercosis, that is Tinea solea. Then the fibropolycystic liver disease. Now remember, they will lack the 3-layered cyst as well as the protoscoliosis, and numerous cystic lesions similar to solitary cyst covered by cuboidal to flat biliary epithelium can be seen over here. Amoebic or pyogenic abscess, if you see, again they are lacking the 3-layered cyst as well as the protoscoliosis. Nuclear fragments with inflammatory cells are present in case of amoebic abscess. Organisms with foamy cytoplasm and eccentric round nucleus is there, and basically ingested RBCs are pathognomonic of Entamoeba histolytica, and the trophocytes, they look like the macrophages. So these are the important differential diagnosis of hydatid cyst. Then the diagnosis is usually made by ultrasonography or CT scan supported by positive hydatid serology. So what are the laboratory evaluations that are available in today's age? So monoclonal antibodies to hydatid antigens can be detected by immunoelectrophoresis, by ELISA and immunoblots. Immunoblots, they have the highest sensitivity, followed by ELISA and immunoelectrophoresis. Antigen assays, they have more specificity but lower sensitivity than antibody assays. Unruptured cyst may not produce antibody response. So what is the treatment over here? The treatment, you have to go for surgical resection. The cyst rupture can occur during surgery, which can give to anaphylactic reaction. So you have to be very, very careful. Puncture, aspiration, infusion of protocollicidal agent can also be done, and reaspiration can be done. It is a preferred technique due to the lower risk of anaphylaxis or recurrence. Okay. What are the prognostic factors for hydatid cyst? Although mortality is uncommon, fatalities have been reported in rare cases of anaphylactic shock or cardiac tamponade. Ruptured cyst disease may require lifelong antiparasite therapy to prevent recurrence. Okay. So this is all about your hydatid cyst. So I have discussed each and every point in detail. So I'm just going to repeat the questions. So first of all, they can ask you enumerate all the organisms in the Echinococcus granulosus complex of organisms. Secondly, they can ask you which is the most common out of all these species. Which one is causing the alveolar disease commonly? Okay, which one is invasive? They can also ask you what are the different sites, okay, and which is the most common site for the hydatid cyst and what are the other sites for hydatid cyst. What are the 3 layers? They will ask you 100%, they will ask you 3 layers. What are the clinical features, how they present, so the clinical features will depend on the symptoms, that is basic, depend on the site of the hydatid cyst, okay. Then apart from that, you will have to identify all these 3 structures microscopically, okay. So I have already highlighted them in details over here. Okay, coming to the next important organism is actinomycosis. Okay, so next, very importantly, we are going to discuss about actinomycosis. Now actinomycosis, if you see, it is a rare chronic disease which is caused by Actinomyces species, which is an anaerobic gram-positive bacteria that normally colonize the human mouth, digestive and genital tract. So there are 3 important clinical presentations of actinomycosis. One is cervicofacial actinomycosis, which is following dental focus of infection. Pelvic actinomycosis in women with an intrauterine device or IUD device, and pulmonary actinomycosis in smokers with a poor dental hygiene. So these are the 3 important clinical presentations of actinomycosis. Very, very important exam question, viva question. Actinomycosis may mimic the malignancy process in various anatomical sites. The most common cause of actinomycosis is Actinomyces israeli, Actinomyces jeranesi and Actinomyces gravenetzi. Actinomycosis is characterized by a pyogranulomatous infection, common involvement in polymicrobial infections, and these organisms are usually normal commensals in the oral cavity, tonsillar crypts, genitourinary tract and lower gastrointestinal tract. Okay. So what are the clinical features of this disease? They present as an indolent, slowly progressive pyogranulomatous disease. Now the orocervicofacial variety can present with abscess formation with sinus tract, purulent discharge, fistula, tissue fibrosis and lumpy jaw formation. Okay, now the one involving the lungs, the pulmonary variety can present with pneumonia characterized by chronic cough, dyspnea, fibrosis and cavitation, whereas the disseminated variety can present with low-grade fever, weight loss, tissue-specific symptoms, and the one which is associated with IUD usage can present with purulent vaginal discharge, foul odor and cramping. So what are the sites? As I have already previously mentioned the different types. Okay, so the sites are mainly orocervical facial, which is the most common site in more than 50% of the infections, the uterus for the pelvic variety, okay, or the pelvic actinomycosis, and then basically disseminated variety can present which is presenting in the chest and abdominal cavity, lungs, liver and the CNS. If you look at the pathophysiology, the infection is initiated upon access to the tissues via trauma, surgical procedures or foreign bodies. Formation of dense, now remember this actinomycosis is characterized by the formation of dense intertwined filamentous bacterial aggregates. Okay, so there are dense filamentous bacterial aggregates are formed. Okay, and this bacterial aggregates that is basically formed, this is basically called as the sulfur granules, and in this particular manner when the bacteria is aggregating, okay, it is actually excluding oxygen. It is actually keeping out oxygen. It is keeping out all the host cells and the immune mediators. Thus, they are enabling optimal growth. So this will be asked, what are sulfur granules? Sulfur granules are nothing but dense intertwined filamentous bacterial aggregates. And what is the use of the sulfur granule? Why it is there? It cuts out oxygen. It cuts out the host cell and immune mediators, thus allowing the bacteria to grow very, very optimally. Okay, so this is the importance of the formation of sulfur granules in case of actinomycosis. So let us see the different types. First, we will read about the cervicofacial actinomycosis. It is the most frequent clinical form of actinomycosis and lumpy jaw syndrome, which is associated with odontogenic infection. Someone around here, some infection is there. Okay, is most common clinical manifestation, representing approximately 60% of all the cases. The predisposing conditions include poor oral hygiene and oral mucosal trauma. Now, cervicofacial actinomycosis usually involves tissues surrounding the upper maxillary, expansion of the jaw or lower mandible. So they involve either upper or lower mandible, including the mandible itself in approximately 50% of the cases. It involves the cheek in 15% cases, the chin in 15%, and submaxillary ramus and angle in 10% of the cases. Coming to genitourinary tract of actinomycosis, it is the second most frequent clinical form of actinomycosis. The main clinical feature of genitourinary actinomycosis is pelvic actinomycosis in women using IUD. Actinomycosis IUD associated infection is infrequent but is clearly associated with the duration of IUD use. Hence, it is recommended that IUD be replaced every 5 years. Now, during IUD associated actinomycosis, abscess formation is frequently observed in the genital tract and creates dense adhesions with contiguous structure. Now, the next important variety is the pulmonary actinomycosis. It is the third most common variety of actinomycosis. Pulmonary actinomycosis results mainly from aspiration of oropharyngeal or gastrointestinal secretions. Individuals with poor oral hygiene, pre-existing dental disease, and alcoholism, they have an increased risk for developing pulmonary actinomycosis. A direct or indirect extension from cervicofacial infection to the thorax may also lead to pulmonary actinomycosis. The most common symptoms are non-specific, similar to those of other chronic lung infections like cough, hemoptysis, dyspnea, chest pain. Okay, so these are basically again important points with regards to pulmonary actinomycosis. Then comes digestive tract actinomycosis. Remember, appendix, cecum, colon, they are the most frequent abdominal sites of actinomycosis, which can occur weeks to years after GI mucosa disruption, and for which previous surgery as for appendicitis or colonic diverticulitis with perforation are predisposing factors. Patients with ulcerative involvement of the esophagus mainly have dysphagia. Patients with appendix, cecum or colon actinomycosis frequently present with abdominal pain with a palpable mass. Patients with liver and biliary tract actinomycosis frequently have right upper quadrant pain and icterus. So these are the different varieties of actinomycosis, okay, and the way that they present. The most common being the cervicofacial, second genitourinary, third is pulmonary variety. Now remember, most pathogens will grow on chocolate blood agar at 37 degrees centigrade within 5 days. These are gram-positive filamentous bacteria staining negative with modified acid-fast stain. Now very importantly, okay, I will first discuss the important histological descriptive points or microscopic point. Then I am going to show you each and everything in the diagram. So microscopically, they are characterized by the presence of large basophilic filamentous bacterial aggregates, also called the sulfur granules, that stain positive on the GMS, Grocott's methamine silver stain, but negative with Phyte and traditional AFB stain. Typical sulfur granules are evident in the midst of suppurative inflammation. So there is a suppurative inflammation, and within that, this particular characteristic basophilic filament is present. The sulfur granules are actually conglomeration of filamentous gram-positive bacilli trapped in a biofilm-like material. These are seen in the center of suppurative inflammation, as I have already explained. These bacilli are bordered by eosinophilic amorphous material with club-shaped configuration. This is called as Splendor-Hüppeli reaction. And this Splendor-Hüppeli reaction of phenomenon is characterized by aggregates of bacteria surrounded by radiating intensely eosinophilic material. This eosinophilic material is thought to represent deposits of antigen-antibody complex and debris from the inflammatory cells of the host. So let me show you. As you can appreciate over here, this is at the center. As you can appreciate, you have the sulfur granules. Okay, so at the center you are having basically the sulfur granules, and at the periphery you can see a very pinkish, okay, light pinkish eosinophilic material. Okay, over here also you can see a light pinkish material over here. This is basically the eosinophilic splendor-Hippel reaction, and you can see that they are basically they are surrounded by suppurative inflammation. Again, over here also suppurative inflammation is there. So as you can see in this particular diagram of actinomycosis, so at the center, okay, you can see the granule which is composed of masses of gram-positive bacteria with branching filaments. Okay, surrounding this there is an eosinophilic substance, as you can appreciate. So these bacilli, they are bordered by eosinophilic amorphous material with club-shaped configuration. This is called as splendor-Hippel reaction. Remember, this is basically representing antigen-antibody reaction and some debris. Okay, now surrounding this particular reaction, you can see over here the third important thing, this point. What is this? The third important thing over here is surrounding dense sheet of neutrophils. You can appreciate over here. Okay, they are actually extending till here. There is a dense sheet of neutrophil over here. And surrounding the suppurative foci, there's a chronic inflammatory cells are present. So this is the area where the chronic inflammatory cells are present, comprising of lymphocytes, plasma cells, histiocytes, few multinucleated giant cells can be seen as well. So I'm just going to repeat once more. At the center